Here we'd be concentrating on perioperative glycemic management. So, basic introduction is that there are three domains of blood sugar. We all know that. That's the basic ABC. That we will talk about the crests and the troughs, that is hyperglycemia and the hypoglycemia, and the gap between them, that is glycemic variability, which is very important. And each of these domains have shown to be independently associated with increased mortality in critically ill patients. And hyperglycemia and GV, that is variability, are associated with increased mortality in patients without diabetes. So, if you look at what's the current scenario, hyperglycemia is reported to be 20 to 40% of patients undergoing general surgery and approximately 80% of patients after cardiac surgery, because that's a very big stress situation which we are dealing with. And 60% of patients admitted with new hyperglycemia had confirmed diabetes at 1 year. So, this part also has to be talked about. And the intermediate aspect is the stress hyperglycemia. That means under a stress situation, it is getting unmasked. This may go back, this may not go back. So burdens and risks, obviously, there are a lot of things happening at the time of surgery. The internal milieu, the hormonal milieu that was at a plateau stage suddenly gets haywire with the stress of anesthesia, with the stretch of putting another knife and scalpel. And it also depends on the way you are doing the surgery, where you are doing the surgery, when you are doing the surgery, and how long you are doing the surgery. So these points are important. So anatomic location. Suppose eye surgery, something else, then intermediate grade, a laparoscopic cholecystectomy, then you undergo a CABG, then you undergo renal transplantation, then you have a complex oncological surgery going on for 16 hours. So these will actually also determine what type of glycemic variability is going to attack the patient. And also the intraoperative fluids and nutritional support what you have given previously, as well as the perioperative and the postoperative period. Type of anesthesia, definitely, whether it's a general, local, etc., will also be one of the factors or variables in this particular aspect. Now, just putting up some statistics, four articles are quoted below. You can see in different departments like elective non cardiac surgery, type 2 diabetes undergoing total knee arthroplasty from orthopedic section, major non-cardiac surgery, and let us talk of elective CABG. So you can see that in the first category, incidence of mortality was 3 to 5% at 1 year in patients with preoperative blood glucose between 60 and 100 versus 12% in patients more than 216. So these are all statistics. Only it harps on the point that these factors have to be kept in mind when we are treating the patients. Some of the slides that I prepared has been done by AI. That is a disclaimer. It has been done with Notebook LM. Poor preoperative control independently predicts complications. We have collated the data and it shows in the orange or red zone. You can see that how statistically significant surgical site infections, the delayed healing, and the prolonged stay is being happening when the HbA1c is moving over 8.5. When it's below 8.5, maybe situation is a little bit better, but it's a linear concept. That means with increasing HbA1c, increasing problems. But when you're crossing 8.5, it's obviously a red line which is being crossed. Now, pre-operative evaluation. So, nutritional assessment is very important. What you are doing within 24 hours of admission for all surgical patients. There will be some patients who will be just for daycare. There will be some patients who will be just for 1.5 days, and there will be some patients who will be for a week. So that part has to be taken into account. The nutritional support, whether prolonged fasting you have done. Usually, prolonged fasting is avoided in patients with diabetes. Low carb diets facilitate insulin dosing and result in improved glycemic control. And also, the dietitian's role comes into play, like how much calories per kg per day you will provide. Like critical ill patients require decreased caloric intake, approximately 15 to 25. But I put a disclaimer here, some patients are hypercatabolic. In those circumstances, things may be different. So, this is just a general statement. Suppose we say in most of the patients that we deal with, a diet between 1800 to 2000 calories approximate for most patients, but definitely this is a generalized statement. Pathophysiology, as I had already mentioned, a lot of things happen and the balance tilts to one side between the glucose utilization versus or vis-a-vis the glucose production. So what really happens is something like this. The counter-regulatory hormones take the lead in these circumstances. The first to talk about is cortisol. What does it do? It does gluconeogenesis. That means the hepatic glucose production, HGP, is increased. And the catecholamines, they suppress the beta cells to produce insulin. And third, because of the lipolytic state, the free fatty acids in the circulation will decrease the tissue uptake in the muscles. So three things are happening. Your utilization at the periphery is reduced, your production of insulin at the pancreas is reduced, and the production of glucose in the circulation is increased. So all these will ultimately add up to increase the blood sugars. Now question is, this insulin resistance, how fast and how long? Most intense in POD1, because that is when the system is acclimatizing to the problem that has happened to the patient. But researchers say that it can be as long as 9 to 21 days. It's a big, the coefficient of variation is quite wide. And prolonged period of metabolic chaos goes on during this period. And so we have to be specifically careful about what changes are happening. Sometimes what happens, the endocrinologist like me is called for a referral on POD1, and then I'm called just before discharge. It's a huge problem. In between, what happens, I'm not aware. So what happens, that the consultant tells me, अरे हम discharge नहीं कर पा रहे, sugar 300 हो गया. So you have to call me in between as well, because the milieu is changing every day, and you cannot say that just like a magic, I will fix one dose on the POD1 and that will translate till the patient is discharged. So those points are very important, that this is a dynamic situation. So I write, just to be medically correct, if I am pulled to court, the last line will be, this is a dynamic situation and the CBG parameters will guide further dosing. This line usually I write at the end of the referral sheet. Principles of management patients undergoing surgery. Obviously, what type of diabetes you are dealing with is very important. Type 1, type 2, gestational, pancreatogenic, drug induced, or malnutrition related, etc. So that part is important. HbA1c should be done at the very beginning. Lot of reasons for this. Whether you are distinguishing between stress and previous diabetic, and also medico legally. Suppose the surgeon will want to operate. If you're in a corporate hospital, they will not refuse patients. So they will say, "Isko to prepare karna hi hai. I will do OT tomorrow. Please prepare the patient today." So what happens, at 9 o'clock at night, I get a call that tomorrow first case is a CABG patient. Now HbA1c is 8.5, sugars is 321. So what do I do? It's something like in cricket, I have to score 36 runs in 6 balls. So this is not possible. So some things have to be explained. So HbA1c doing at least saves my skin in a way that I write, the previous control was suboptimal. This line I write just to save myself. Then the surgeon will do the operation. And then coming to the next point, glycemic goals. Obviously, my next speaker will also talk on this. I will just gallop through this. The most important thing is that usually it is 140 to 180 with some caveats. In some cardiac surgery, it is seen that 110 to 140 can be good, but there's a caveat, that without causing undue hypoglycemia, because we know any hypoglycemia in a scarred tissue can be potentially arrhythmogenic. That can be a lot of problems. So the usual target is 140 to 180. And also I will relax this when I'm dealing with the cancer care, end of life care, terminal care, CLD patient, CKD patient, where there is high chance of hypoglycemia. So in those circumstances, I will relax the borders. Maybe under 250 will be good. And for CABG patients without undue hypoglycemia, I will keep it around 110 to 140. But the other patients, maybe I will keep it at 140 to 180. That is a broad regimen. And what Anchin has already mentioned, that these were the trials on which these were actually designed. So we tried to find out a therapeutic sweet spot where sugars can be kept without causing problems in increase in mortality in infection and increase in mortality due to hypoglycemia. So this is basically a compromise approach which has been designed from these trials. So this is a U-shaped curve. 140 to 180 zone is a safe zone, below which you are in a soup, above which you can be in a soup. So this is the green zone which we should be using in most of the circumstances. Now, in peri-op setting, what do we do? Identification and treatment of hyperglycemia prior to elective procedures. You are admitting the patient for a cholecystectomy. It's not an emergent thing. You are admitting for an eye surgery, though eye surgery is most of the time now cataract surgery is a daycare surgery. So in those circumstances, you will obviously evaluate and try to bring the HbA1c and do a good control so that the optimal outcome can be achieved. But obviously, there will be circumstances where you have acute appendicitis, you have some acute other problems where you have to immediately operate. So there has to be some way out. As far as possible, the sugar control has to be brought down. So these are the various guidelines from anesthesia, ADA, AAC, all say to keep around 140 to 180. So I'm just skipping through these. These are various societies which have given the guidelines. Now, determining the preoperative medication use, this is very important when you are admitting, and preoperative evaluation, this part becomes very much important. Though it's a busy slide, you can just look at the left end and the right end. So these are the drugs, what you should do with them at the right end is given. So when you are dealing with metformin, it's a very common drug which is used right, left and center. So in those circumstances, we usually stop it 24 to 36 hours before. Nowadays, it's said about 24 hours. Suppose tomorrow morning the patient will undergo surgery. Today morning, he can take the last dose. So 24 hours should be the minimum gap. Sulfonylureas obviously will stop because they have the potential to cause hypoglycemia. Thiazolidine you can continue regular use provided it's a short surgery. You are not undergoing fasting and all those things. Just the eye surgery is being planned or the cholecystectomy will be done. So we'll just give the dose, get operated, and next day onwards the patient will be on normal diet. Now, glinides obviously have to stop because the behavior is almost close to a sulfonylurea. Alpha glucosidase inhibitors, you can continue, but obviously, if the patient is fasting and other GI problems are happening, you will stop it. Regarding DPP4, obviously, it's a good drug where you can continue, no issue of hypoglycemia, etc. No dose reduction required in most of the circumstances. Now, regarding GLP, SGLT2, and insulin, I have devoted separate slides. I'll talk about that. So, euglycemic decay is something which is really underdiagnosed. So, if you do not suspect, you will never find it out. So, we have to understand that this decay is actually having normal blood sugar because you are actually causing therapeutic or pharmacological sugar leakage through the urine. So, the gap or the swing in the sugars will not be so high. So, you may not be able to diagnose in most circumstances. So, the best part of it is you just stop the drugs about 3 to 4 days before the surgery. Artegliflozin is not so much used in our country, so forget it. It's about 4 days in the guidelines. Most of the other things, DAPA and EMPA, they have to stop about 3 days before surgery. GLP, it's a boom now in the market, and for the next 5 to 10 years, maybe this is going to rule the roost. So, in those circumstances, what new things are coming up is that the aspiration aspect is a headache for anesthesiologists. Now, you are giving not liraglutide, which is daily. Now, you are talking of tirzepatide and semaglutide, which is given weekly. It's a long-acting thing. So best thing is to withhold the medicine at least 7 days prior. And some guidelines I have read said at least 1 month prior in big operations because there is a stasis or lagover or carryover effect. Like what is happening, usually the food takes 4 to 6 hours to pass the pylorus. But in those circumstances, it may be 6 to 7 hours, even 10 hours. So the patient who has taken a meal last evening can bother you the next afternoon or the next noon also if the patient is on a GLP-1. So in those circumstances, it said if it is a daily agent, hold on the day of procedure like liraglutide. If it's a weekly, at least 7 days. But I am a very conservative endocrinologist. I tell them it's a planned surgery. At least stop it 2 to 3 weeks prior to this thing. And even if this has not been done, then what do you do? The anesthetist will ask you. So mitigation strategies are there. Like we consider gastric ultrasound to quantify how much content is there in the stomach, and we decide what to do next. So there are some regimens in anesthesiology, full stomach precautions they follow. Okay. And consider bridging with insulin if the control worsens. What do we do day before surgery? Busy slide, but the most important thing, if the patient is normal diet until midnight, includes those permitted clear liquids until 2 hours prior to surgery. 9 o'clock in the morning surgery, 7 o'clock, he or she can take some liquids, and everything she had last night is okay, fine with the surgeon. So in those patients, you reduce the glargine, detamine is no longer used, or the long acting ones, about 75 to 80% of the usual dose. And what do you do? The short acting ones on the right side, obviously, if the patient has taken the meal, you will obviously give it. But what do you do on the day of surgery? The short acting ones have to be omitted because you have not given the food. So, what will you cover with that insulin? You will not do that. And for the glargine and the NPH, if you are at all using, so obviously, dose has to be reduced. And I personally do not prefer 70-30 pre op, obviously. So, basal bolus will be good. Correctional, I would skip only to say that when you are using correctional dose, the dose has to be reduced in those who potentially are insulin sensitive and has to be a little bit more than what is predicted, who are potentially insulin resistant, which is written in the blue column. Problem may arise with glucocorticoids and when enteral nutrition is happening. So I work in a tertiary care hospital where renal transplants go on. 60 mg prednisolone is given in the morning. So try to match with either an NPH. In those who are having a pre-lunch surge, try to match with the second generation or second generation like Toujeo, where you are having a pre-dinner surge because a long duration action. So in most patients, I give at 7 a.m. in the morning, Toujeo, and that patient does well when the patient is having a pre-dinner surge. Intraoperative is just on the part of the anesthesiologist, so I will skip. The last part I will take just 30 seconds more. The post-operative part, it is where the anesthesiologist hands over the patient to you. In those circumstances, obviously, you have to do repeated blood sugar testing, and the switching, I think my next speaker will also talk about this. So switching, most important will be you calculate the total dose. This is what I do. I've just taken a chart from my hospital. Patient has come at 9 a.m. with 356. I just divide it by 100. So it's about 3.5 when you are doing a 40-40 solution of normal saline and 1 unit of human regular insulin. You bring it down, ultimately you reach somewhere at 22 hours, that is 10 o'clock at night at 142. It is best to switch in the morning, but some of the consultants switch it in the night time because the Lantus or the Toji or the Tresiba can be given so basal control in the morning. So ultimately what you do, you just check whether the patient is having high drip rates, high glucose levels. All these things will deter you for switching over. But if those things allow you and the oral nutrition is ensured, you can go for switching over. And this is how you do 50-50. You just divide the doses, and I progress throughout the day. And lastly, I will talk about the last slide is about technology in hospital. This is upcoming in most of the new big hospitals. This is being used. So many people ask about CGM. So what is the recommendation now? That continue personal CGM and pumps if patient is competent and resources allow. If your brothers and sisters in the hospital can actually handle those situations. Otherwise, every 30 minutes you are going to get a call. So discharge is the last part. This is the time when you have actually to transfer back to the old regimen. I see many consultants, surgeons say continue anti-diabetic medications taken earlier. This is wrong because the patient is just eating a little bit. The patient was taking 70 units of insulin, 3 oral medications, and the patient is just going home, getting acclimatized to the home diet. And you are putting all those medications together, and then there will be a call from the resident as well as the emergency. Patient has come back with a hypoglycemia. So that switchover in the 7 days is very important. So start low, start afresh, then gradually build up because at 7 days, most of the surgeons will call for a review. So that is the best time to actually reschedule the doses. So last summary slide is this: pre-op screen A1C, goal less than 8 is the best. Stop SGLT2 inhibitors, GLP-1 receptor agonists, intra-op, target 140 to 180, IV insulin is the best. Avoid tight control in the wards. Target is 100 to 180. Basal bolus is the best, as my previous speaker has said. No insulin sliding scale, but I accept in many situations it becomes more a majburi or compulsion that it's still being used. And at the discharge, medical reconciliation, survival skills have to be talked about, and follow up has to be scheduled so that we can bring back a plateau state to the glycemic control. Thank you.